Welcome back to Goalie Training Pro TV. Today we are talking all things FAI. What is femoroacetabular impingement? How do you get it? How do you reduce your risk of getting it? If you've got it, what are the treatment options? Let's go. So the hip joint is a ball and socket joint, and it's a relatively deep socket compared to your other ball and socket joints like your shoulder. Your shoulder has quite a shallow socket and quite a big head on the head of your humerus. The hip has a deeper socket, so it's a lot more stable joint. You don't often hear people just randomly dislocating their hips. A hip dislocation is like a major medical emergency from a very high force trauma. So you can see how it just fits in there, boom, like that. You get these degrees of freedom. But you can also see that there's sort of bony bits that can hit each other, and we don't all have exactly the perfect shaped femoral head to fit the exact shape of the socket, which is called the acetabulum. So we can create some issues in there. So that's what it looks like in 3D. I tried my best artistic skills here to draw it out on the whiteboard. So this is, you're basically looking at this, comme ça. This is your femur, and this is your acetabulum. And so the acetabulum has a couple different parts. It has a cartilage, so in the inner surface there's an articular cartilage. It has a labrum, which is sort of little more fibrous cartilage ring that gives the joint a little bit of cushioning, a little bit more depth and stability. And I drew another little picture over here for you that shows it a little better. So this is an end-on view, like this, as if we kind of looked just at this on end. You would see there's a cartilage, articular cartilage, covering the whole interior surface, and then there's sort of this labrum ring around the outside. So what is FAI? Well, FAI happens when, you're a little close, do you mind backing up a bit? It happens when there's a couple different types of FAI. I'll use the blue marker for FAI. So we can have a cam type of FAI where, and really this isn't quite to scale, but where the surface of the humeral head, or even this is called the neck of the femur, or I think they also call it the surgical neck of the femur, is either misshapen. So some of us are just born with a funny shape, but over time, if we keep sort of irritating that, we could build up a little more of like a bony callus. So then when you move your hip through range of motion, you can see that it's going to pinch on the rim of the acetabulum, or impinge on the rim of the acetabulum. There isn't space, so they're going to smash into each other. And then what could also happen in there is that this cartilage could end up getting pinched or torn a little bit, and then that creates a problem as well. It's sort of like having a meniscal tear in your knee or a torn labrum in your shoulder. It'll kind of catch you and give you a pinch. So that is called, this is called cam impingement. And I read a research article saying it's the most common in goalies. Now, there haven't been extensive studies in hockey goalies with hip impingement, so I don't think that's like the end of the story, but that's what they found in their research. Then there's also a pincer type, which is where so the acetabulum kind of gets a bony hook or bony overgrowth that really has the same impact. So some people get tied up in whether they have a pincer or a cam. I really like saying the word pincer. I just realized that. But pincher. I like pincer better. Pincers. But some people get hung up on whether, I've got a cam or I've got a pincer. It doesn't really matter that much. And a lot of people end up having a little bit of this and a little bit of that, which they call a mixed impingement. So what do we do? Number one, how do we not do this, please? We'll get to that. I'll hit that at the end. But let's say, you're getting some hip pain. I'm always suspicious, and a lot of the time it is the truth. that or it happens to be the fact, when I have a goalie who is like, oh, I tweaked my groin, and then they, go through the rehab and it's feeling good and they go back out, I tweaked it again, the exact same spot. Oh, I tweaked it again. And then it's like, oh, but it felt better, within a day or two. Oh, yeah, I pulled that muscle again. I'm immediately suspicious that this isn't a muscle that's repeatedly getting pulled in the exact same spot. I'm suspicious that I think you actually were smashing some bones together and that gave you a pinch. And it can give a lingering pain, because when you smash bones together, just like when you smash your skin or pinch your skin, you'll get a bruise. So you can get sort of a bone bruise to varying degrees that can give you like sort of a lingering discomfort, but not really the same as a muscle tear. So that's one that I always, and so I think that comes to one of the best sort of prevention things is, if you're having that, or if you're having kind of a pinching or a block or something going on with your hip, and often you feel it in the front towards the groin, so it's easy to mistake for a groin tear, get it checked out. Go see a physiotherapist. There's some really simple tests, I'll tell you about one a little bit later, that they can do to say, yeah, you're getting an impingement. Well, what do we do then? Well, then we know. So instead of, let's say, I remember a guy we had at Revolution who just couldn't squat. He would get to probably a third depth of the squat, and he's like, I'm stuck. Like I can't do it. And he had an impingement. He had hip impingement. So instead of being like, well, we got to get you to thighs parallel, get lower, we just were like, okay, that's what your limit is. So that's the range of motion we need to train you in. And we tried, we used a wider stance, change foot position to open up a little bit more room. But we don't keep just hammering, thinking that's going to make it better, because it's actually just going to make it worse and cause more buildup of bone. So it's going to accelerate the dysfunction that you get. Another sign of FAI, in addition to sort of getting that pinching or blocking feeling, is losing range of motion. And often it's losing external rotation, which is the opposite of the butterfly, but usually goalies will feel like they're losing their butterfly as well. And sort of over the course of a year, it's like, wow, now I've lost a bunch of mobility. That's another sign. So again, another reason to get it checked out, because also maybe you're getting this kind of impingement type symptoms because the femoral head is kind of jammed to the front of the joint or jammed to the back of the joint, and that's why you're getting those symptoms. Really, the bony changes aren't that bad, and a physiotherapist with some good manual therapy skills can actually kind of stretch that capsule and mobilize that capsule and get the hip moving way, way better. I think some of you get scared when you have pain and you think, maybe this is hip impingement, then I'm gonna have surgery, then it's gonna be the end of my career. It doesn't need to be like that. So just get it checked out before it becomes something that's a little bit more nasty. There is a fantastic research article. It's Whiteside et al. I can drop a reference in the description below. But what they looked at, they were one of the first really to look at the actual sort of kinematics of goalies moving with their pads on in specific patterns. And so looking at not the forces, but the range of motion and the difference between active range of motion and passive range of motion. And the biggest magnitude of sort of deviation from active end range. So active end range is just, okay, well, how far can I just with my muscles, internally rotate at my hip, let's say, so turn my pad inward. And then passive would be if somebody came and kind of gave me a little boost, a little help, not twist my leg off, but give me help. And what they found was basically the deceleration of like a T-push where you're sliding your skate along the ice surface, but where your hips then are gonna come and snap around over that sort of exceeded the active range of motion limit for hip internal rotation. So that was sort of the biggest finding, more so than going into the butterfly. So again, they weren't measuring forces, they weren't saying cause and effect, but you might kind of surmise that, okay, so actually maybe that is more load on the hip than even going into the butterfly. So really interesting, because if you were around any goalie camps 5 to 10 years ago, what like all you heard at the start was like T-push, And specifically, it's when you decelerate from the T-push and then kind of snap your hips around over it to square up. This study was published, I think it was published in 2015, which means the actual research was probably done sometime 2014 or earlier. So before the RVH, they didn't look at the RVH at all. So, you know, I think too, if we look at when doctors test you for hip impingement, or your physiotherapist tests you for hip impingement, they'll do a test where they bring your hip into flexion, internal rotation, and adduction, which is kind of the position of the RVH. Let me pop down here and show you. So I just have my shorts on and my pads on so you can kind of see a little better what's going on at my actual hip joint. So if we talk about flexion of the hip, flexion is sort of bringing your thigh up towards your chest. That's hip flexion. Internal rotation is this, rotating your thigh inward. It's the position you're in when you're in the butterfly, hip internal rotation. And adduction is bringing your knee or your thigh towards your midline. So this is abduction, this is adduction. So when I'm in the RVH, I'm just like pad on post, but when I'm in the RVH, you can see there is internal rotation, there is adduction, so my thigh is angling inside my midline. There isn't a whole lot of hip flexion here, so that isn't too much of a concern. But you can see too, as I get more over the puck, or you know, if I'm going to cover up the puck, then there is more hip flexion. So some of you might notice, oh, when I'm in the RVH and I go to cover the puck, I get a bite, or when I, you know, come into more hip flexion. When you're in your butterfly, you've got the internal rotation, you've got some adduction for sure. Again, not too much flexion until you're, you know, even here if I'm getting out over the puck, that isn't a whole lot of hip flexion. But just like in the RVH, if I'm in this position and then I start, you know, poking at pucks or covering pucks with my glove, that might put me into a little more hip flexion or a little more of an impingement position. I'll point out one more issue I see with the RVH, and it's that I can kind of jam myself with my pad or my skate blade or whatever against the post. The post is fixed, so then I can kind of lever myself, and that also lets me exceed that active range of motion. So, you know, maybe my normal adduction is here, but if I crank myself, you know, and try to get my hip at the post, and it's, you know, easier with your goalie pants on, but now you can see where I'm sort of forcing beyond my normal range of motion. Some of the non-surgical treatments for FAI include physiotherapy. So again, mobilization, looking at how the hip joint works, how you use the muscles around your hip joint so that it's a little bit more stable and it's getting less kind of play or less wear and tear. And that actually can get you some great results. Even just looking at your biomechanics on the ice, is there something that you do, you kind of over-exaggerate a technique that maybe you use a little bit too much, so we can use a different technique to reduce that grind on the body. Another non-surgical treatment is platelet-rich plasma. So what they do is they take out a sample of your own blood and they spin it in a centrifuge to just get the platelet-rich plasma, not just the syrupy stuff. And then they inject that into your hip joint with the idea that it's going to promote healing and almost a regeneration in the hip. Now, the research is pretty limited, especially in terms of hockey goaltenders and, you know, does it work or doesn't it work? I know they did a study looking at it following hip surgery to see, you know, if maybe it had an impact. That the one study I looked at, it didn't show a big impact. It doesn't mean there isn't one. It just means that the sample size or what they were looking at, there wasn't a big change. I've had anecdotally, I've worked with a few goalies who've had it, and some have had really great results with it. So, you know, it's still up in the air, but it's an option. Then, here's the thing too, people are, you know, I talked to some goalies who, you know, are playing at a good level and they're ready to move up to the next stage and they have hip impingement, and the hip impingement is limiting them from being able to perform the way they need to perform to have success on the ice. They've lost range of motion, they have constant pain, they can't move the way they need to move, and they'll say, but I don't want to have surgery. And it's like, surgery is the only answer. There isn't a pill or a needle or anything you can get that's going to fix this. So what they do is, it's an arthroscopic procedure, so they don't open up your whole hip joint, but the doctor will go in, the surgeon will go in, and they'll down those bony abutments so that your hip joint has room to move again. And then they might repair the labrum when they're in there. They might trim it down, or they might repair it when they're in there so that it has this nice congruent shape again. The recovery is funny. I've helped goalies rehab a bunch of these working with their physiotherapist. I'm not a physiotherapist, I'm a strength coach, but working with the physiotherapist, I've rehabbed quite a few of them, and they're never straightforward. So when I worked at the sport medicine clinic, we rehabbed a ton of ACL reconstructions. We were kind of known around the world for ACL reconstructions. And you knew, like, okay, at 3 months, you should be able to do this, at 4 months, 5 months, 6 months, you know, and exactly when everything should be feeling good. And if it wasn't, then it's like, okay, what's going on? The FAI surgery is like the opposite. So, you know, a goalie might come in 6 weeks post-op, oh my God, my hip feels so good, I have no pain, I can move, it's amazing, like this is the best thing ever. And they might walk in the next day being like it feels exactly the way it did before the surgery. Like I'm having the exact same kind of pain. I don't know, like I think maybe they didn't get it, or they didn't do it right, or something like that. And it just goes like a roller coaster like that. Even when you can get back on the ice, you know, they'll say, oh, you can get back on the ice maybe around 4 months or something like that. That doesn't mean back to playing. That means back to doing like just some skating in your sweatpants. No, like nothing from your knees. Then, you know, there's a graded return to play that takes quite a while as well. But even then, even when you get back to playing, it's like, oh, I can play now. Goalies will still have discomfort. And I find really the first season, you know, the first year, it's like, I don't know, it still kind of hurts sometimes. And, you know, it's not perfect. And some days it feels good, some days it feels sore. But then by the time we come around to the next season, they almost have forgotten about it. And it's kind of cool too, because when you have this impingement, you lose range of motion, you sort of you forget what it feels like to have a hip, because you didn't really have a hip anymore. It was like this rusty gate in there. And so it feels really, really nice. But it does take a while to get there, and it is going to be a bit of a roller coaster. The nice thing about this surgery is, like ACL, they've put in a graft and they've stitched it in, and the graft actually kind of dies a little bit before it gets its own blood supply and then gets strong again. So really, if you do something wrong, you can tear that graft, and then you are back to square one. With the FAI surgery, you know, it's not to say go out and do whatever you want, even if it hurts, because you can then have like chronic hip flexor pain and other things that can happen. But your wrist, you're not going to like undo what the surgeon has done. Again, listen to their restrictions. Don't do things you're not supposed to do. But when you get back on the ice, it's not like you're going to tear a graft. Okay, let's finally chat about, and I won't say prevention, I'll talk about ways to reduce your risk of developing FAI to the point where you need surgery. There was another study, I can't remember who the lead author was, but they looked at professional hockey players, of skaters and goalies, and they did radiographs. And one of the things they look at is a thing called an alpha angle, which sort of has to do with the angle of this femoral neck. And I think if it's more than 55 degrees, then they're like, oh, you've got FAI. But so, I'm bad with numbers, these aren't the exact numbers, but it was something like 70% of them had radiographic evidence of FAI, but like 10% of them had symptoms. So also it doesn't mean if they see it on the x-ray that's like, oh, I'm doomed. So how can we limit the risk of this developing into something that's going to really impact your ability to play? Well, I think it's important to try and limit repetitions, especially when you're young and developing. And I think we're getting there to some extent. Again, when you used to go to goalie camps, you know, boom, boom. And it was like, the more noise you can make, the better. You know, and that's just kind of extra wear and tear, and you're using energy to create a loud noise. So not to say you can't do the butterfly, but let's not do 400 butterflies in a practice, and it's been a passion idea of mine. Like, I'd love to just have like a butterfly count, like baseball players have a pitch count, which again, I know it's not perfect, but just to be aware of the repetitions. We talked about if your hip won't go into a position and you're not feeling a stretch in the muscle, you're feeling a pinch or a block or something like that, then don't keep trying to hammer into that position. If you're having this recurring little tweak that just hurts for a couple of days and then it feels actually a lot better, get it checked out. So if you have ranges of motion that you can't get into, or you have these little recurring funny tweaks, go to the physiotherapist and get it checked out. Wow, how great would it be too if they said, there's nothing to worry about. Yeah, you tweaked your groin and you're whatever, you're good to go. So get it checked out. And this is where training comes in. So, good training looks after a lot of this stuff, building the mobility. So not just the flexibility, but the flexibility plus the stability, making that joint nice and strong and smart to help kind of reduce the wear and tear. Sort of like having a strong core or torso helps reduce your risk of getting a low back injury. So it's the same type of thing. If you want to check out this video, I created a daily hip maintenance workout specifically for goalies. And the last thing is you can do some equipment modification. So I showed you in this video a couple of things you can do, but it ranges from bungee toe ties to increasing the height of your knee stack, just to take a little stress off the hip joint. So that is maybe more than you ever wanted to know about FAI. If there's something I missed or you have a question, drop it in the comments below. But the take-home message here is, if you're not sure, get it checked out. If you're having hip pain or losing range of motion, get it checked out. If it's nothing, awesome. If it's something, then we know and we can start working to sort of minimize or reduce the impact. Now is the time I'll ask you to hit like, to subscribe, share this video if you wish. That would be great. I will see you next time. How do you like my artwork? Give me a grade on my artwork. If you were my grade 6, or no, grade 9, grade 6 art teacher, what grade would you give me on this composition? Notice the shading is a little darker in the middle to try and give that three-dimensional depth. Take that into account when you're giving me the mark. Drop it in the comments below. Let's see. I'm hoping for a B average. I'd be happy with that. Just like high school. See ya.